He wakes in his own bed after a short hospital stay. The discharge paperwork is folded on the nightstand. The room looks unchanged. The ceiling fan rotates at its usual speed. He is told the procedure went smoothly, no complications. He is told fatigue is expected and rest will help. The word recovery is used. He returns to routine cautiously, without fear. The first days are quiet. He misplaces small objects, a set of keys, a phone left in the refrigerator. He attributes it to medication and disrupted sleep. Family members accept the explanation. The changes are not dramatic. They do not interfere with function. He continues driving. He continues working. He completes sentences. He laughs at appropriate moments. At the follow-up appointment, vital signs are stable. Blood work shows nothing urgent. Imaging from the hospital stay is reviewed and dismissed as unremarkable. He is reassured that healing takes time. He is advised to hydrate and reduce stress. No one uses language of urgency. The situation appears contained. Weeks pass. His handwriting changes. Letters narrow and then widen unpredictably. He misses steps in familiar tasks. Buttons are aligned incorrectly. He pauses mid-action, unsure why he started. The pauses are brief and resolve on their own. There is no pain. There is no fever. There is no loss of consciousness. The explanation remains psychological. The assumption is temporary disruption. This condition does not arise from stress, anxiety, exhaustion, depression, or burnout. It does not improve with reassurance or rest. It is rare. It is biologically distinct. It cannot be self-diagnosed. By the time it becomes noticeable, it has already begun. The first clear boundary appears when coordination fails without warning. A glass slips from his hand. His gait narrows. He stumbles on level ground. There is no vertigo, no nausea, no spinning sensation. Neurological examination reveals inconsistencies. Reflexes do not align with muscle strength. Eye movements lag behind intention. Advanced testing is ordered. The waiting period is short. The decline is not. Brief involuntary muscle jerks begin. They occur at rest. They are not seizures. They are not tics. They interrupt stillness and cannot be suppressed. They increase in frequency. The diagnosis is delivered without ceremony. Creutzfeldt-Jakob Disease, a prion disorder. Not an infection in the conventional sense. No immune response to target. No inflammation to suppress. The name does not explain the experience. It marks the boundary beyond which ordinary illness no longer applies. Prions are misfolded proteins. They contain no genetic material. They do not replicate through division. They convert. When a prion contacts a normal protein of the same type, it forces it into the same malformed shape. This process requires no energy and no cellular machinery. It proceeds by contact alone. The brain depends on precise protein architecture. Shape determines function. As prions propagate, structure collapses. Neurons lose integrity. Synaptic connections fail. Tissue becomes porous. This is not degeneration by erosion. It is a state change. The brain shifts into a form that cannot sustain coordination. There is no mechanism to reverse misfolding. Cells cannot refold these proteins. They cannot degrade them effectively. The immune system does not recognize the threat. There is no inflammatory alarm. The process advances without resistance. Cognitive changes accelerate. Memory fails inconsistently. Distant events remain clear while recent moments vanish. Questions are repeated without awareness. The thread of conversation is lost mid-sentence. Correction increases agitation. Insight fades. Visual processing deteriorates. Depth perception becomes unreliable. Familiar rooms appear altered. Faces distort. Sensory input arrives intact, but interpretation fails. The brain can no longer assemble coherence. Language degrades. Nouns disappear first, followed by verbs. Speech becomes indirect, then fragmented. Comprehension lags. Commands must be repeated. Eventually, they are no longer understood. The capacity to express intention disappears before intention itself is lost. Motor control fragments. Walking requires conscious planning. Automatic movement ceases. Balance cannot be trusted. Fine motor tasks are abandoned. Eating becomes hazardous. Swallowing reflexes delay. Aspiration risk increases. Muscles respond, but control does not. Sleep architecture collapses. Circadian rhythm dissolves. He drifts between wakefulness and confusion. There is no restorative phase. Fatigue accumulates without relief. The brain cannot enter organized states. Behavioral regulation fails. Social filters vanish. Responses become inappropriate. Empathy diminishes. These are not personality traits emerging. They are neurological functions dissolving. Imaging reveals cortical ribboning and signal changes in deep brain structures. Electroencephalography shows periodic sharp wave complexes. Cerebrospinal fluid markers confirm rapid neuronal destruction. These findings do not alter outcome. They mark territory already lost. Time compresses. Weeks replace months. There are no plateaus. Each function lost does not return. Compensation exhausts remaining neural reserve. Failure accelerates. Recognition of family members becomes inconsistent. Faces lose meaning. Names no longer anchor identity. Emotional response to loved ones fades. This is not withdrawal. The neural substrate of recognition has failed. Volitional movement ceases. He becomes akinetic. He does not initiate action. He does not respond to prompts. Awareness fragments and disappears. There is no internal narrative. The self no longer assembles. The body remains alive. Organs continue to function. The heart maintains rhythm. Respiration continues. But agency is absent. Identity is inaccessible. The person who entered the hospital weeks earlier is no longer present. This disease does not allow adaptation. There is no stable impaired state. There is only progression towards silence. Care becomes custodial. Interaction becomes one-sided. The brain no longer participates. The final stage is not marked by pain. It is marked by absence. The systems that once generated intention, memory, recognition, and continuity have been dismantled. What remains is biological persistence without authorship. Death follows later. It is not the primary event. The defining event has already occurred. The loss of self precedes the loss of life. The body continues after the person is gone. Creutzfeldt-Jakob disease does not attack violently. It converts quietly. It replaces structure with void. Once begun, it completes its course. The fear is not in the speed, but in the precision. A single misfolded protein initiates a cascade that dismantles identity without resistance. The brain cannot defend itself. The self is unmade before the body fails. This is pathology of fear. And this fear is real. Because sometimes the most devastating outcome is not death, but the systematic erasure of the person you were, while the body continues without you.